Assalamu alaikum, everyone. Welcome, whoever you are from all over the net. We are pleased to continue our Gulf Interventional Society webinars. These have been very successful, well received, and I think they've been very informative. I'm happy to our guest speaker today, to introduce our guest speaker, Dr. Roberto Garbo, well known. He's the director of the Cath Lab and the Interventional Cardiology Unit at San Giovanni Bosco Hospital in Torino, Italy. He is well known for those people who do CTOs, multiple live cases and recorded cases in Euro CTO. He's one of the active members of Euro CTO Club, so he's the perfect person to tell us about complex PCI. In addition, I want to welcome our panelists, experienced interventionist, Dr. Saeed Sabiq from National Heart Center, Royal Hospital, Oman, and my colleague, Dr. Hatem Al-Lawati, very experienced, excellent interventional cardiologist. These are our panelists, and we have a good representation from the south of Oman, Dr. Muntasir Ismail from Salalah Hospital, and Dr. Amru Sayyid. They have very nice cases they can share with us, and then we'll have a very nice discussion, inshallah. So without further ado, Dr. Garbo, I give you the stage to teach us about complex PCI and making it efficient.
Thank you very much, Adil. Thank you for your very kind presentation. It's a really honor for me to be present in this webinar and to share with you something that I think it's really, it would be much more necessary in this very bad period of COVID-19 pandemic. Because we had in Italy, but I think we will discuss later with you, we have a change. We have 2 or 3 months of low case number, but now we have an increase of very complex patients because people were not able to come in the hospital in that period. Now we have very, very complex patients. And I think that we can improve efficiency in complex PCI. And this is the topic of my presentation. We have what is complex? We know that complex is a multifactorial situation. We have anatomical feature, and we know that the most complex anatomical feature are chronic total occlusion, number one. Then we have because during CTO PCI, then once we open the artery, we need to face for sure about bifurcation, very often left main, and calcification, osteal lesion, multivessel disease, and diffuse disease. This is the anatomy. Then we have the hemodynamic. We can have patient with cardiogenic shock, with the low ejection fraction, and this is an adding complexity. And then we have comorbidities. We know that in our everyday, in our cath lab, we face very older patients, and every year is we can treat almost all coronary lesion with new technique, new device, drug-eluting stent. So we have a very old patient with diabetes, with calcified lesion, and we can have also patient with the prior CABG failure. So we have to mix a lot of situation to understand what is complex. So we know that this is just a picture of the Champion Phoenix trial that show that new antiplatelet therapy are essential to have a good result at the follow-up in this complex lesion, complex patient. And we have long lesion, bifurcation, and what we discussed before. So how to deal with complex lesion? We have that's all you need. A skilled operator, this is the most important part, but we need better device, because in the last 10 years, we have new devices that they change completely our approach to complex PCI. We had new guide wire and microcatheter for CTO, guide catheter extension that are essential. I think that the two most important devices in the last 10 years are guide catheter extension and dual lumen microcatheter. I think that these are the two most important innovations that I can feel they change my practice in CTO PCI, but not only in CTO, also in complex non-CTO PCI. Then we need to have new balloon with very good profile and other device. I will show you some. We want to do practical lesson, practical presentation. So this is the first case. It's a complicated left main PCI. We start with this case. Was not so complex lesion in the right, and then we have this left system. Was a previous PCI. The operator think that the LAD was the culprit of this lesion. He tried before the right. This was the final result for the right. Then after 20 days, he decided to approach the left system, and it should be an easy PCI, but sometimes also an easy PCI can become a nightmare. This is a iatrogenic left main dissection. This is a very, very bad image that we don't want to see in our cath lab, and when we are in the operator of this patient. So it was a dissection of the left main by the guiding catheter. The operator was really able, was not me, was my colleague, to put a guide wire in the LAD. Then the patient had a cardiac arrest. And this is the importance of dual lumen. Was not able with the normal wire to take the circ. So it take an NHancer DLM dual lumen that is 6 French compatible. So it's the only one that you can use with 6 French. You can use and trap with a normal balloon. So in this situation, we will see later different dual lumen like Sasuke, they are very good, or Fine Duo, but this one there are only 7 French compatible for the removal, for the trapping. This is the only one you can trap with 6 French. You can see gain the circ, then dilatation, IVUS, and then left main PCI. Again, rewiring with the dual lumen of the circ after stenting of left main. We will see later a very fantastic presentation on bifurcation lesion, so we can go further. And then this is the trapping balloon. You can see here the trapping balloon in the 6 French and the removal here of the dual lumen. So with 6 French, you can do everything with this device. Kissing balloon, final pots, IVUS, and very good results. So this was really a nightmare that was treated in a perfect way. So dual lumen microcatheter, wiring or rewiring of side branch in bifurcation. We have also several techniques for CTO PCI like parallel wire technique. You can see here, this is the short video on how it's useful also for rewiring in the diagonal after stenting of the side branch. For CTO, we have only now new dual lumen that is not the topic of our talk. His name is Recross, is the new dual over the wire lumen to have 2 CTO wire in the same time. This is a picture of all the dual lumen microcatheter we have now in the market. We have NHancer DLM, Fine Duo, the Sasuke, it's a very good one, twin pass, and then I told you the recross with the 2 over the wire lumen. What about trapping technique? As I told you that you can see here 6 French, 7 French, 8 French. The NHancer RX is feasible, the trapping in the 6 French. No, this is the fine duo. Fine duo is not possible to trap with the 6 French, you can see here, because it's too large, the device. You can trap with in the 7 French guiding catheter with a balloon. The same for Sasuke. The Sasuke, you're not able to trap in the 6 French, but you need 7 French or 8 French. Or you need the new trapping device. This is, we have 2 dedicated balloon for trapping. We have the Trapit for IMDS, this one, and the second one is the Trapper from Boston Scientific. With these dedicated devices, you can trap every dual lumen in the 6 French guiding catheter because the profile is smaller than a regular balloon. Second case, how to deal with a complex STEMI. This is a male 51 inferior STEMI occlusion of the right. The support of the guiding catheter is not so good, even if it's an amplat. So the guiding catheter is a good one, but the support is not so fantastic. You can see how difficult is the wiring of with the Sion wire. And then we were able to reach the side branch here, okay. Then we tried to rewiring of the normal right RCA with a second wire, but we were not able to do that because of the bifurcation, the thrombus, and the angle of the bifurcation in the mid of the right. So what can we do in this situation? Dual lumen microcatheter is the good choice. So we put dual lumen over the first wire, and then with dual lumen you can see this is a real-time fluoroscopy registration, how easily the Sion black went in the right. Because the dual lumen increase the support and increase the orientability of our second wire. And we have you can see in the middle of the 2 black tungsten part of the microcatheter, dual lumen, you have the space in the middle for the second wire. Then dilatation, huge amount of thrombus aspiration. And then in this situation, if the thrombus is not, the manual aspirator is not enough, you can use the Cath Extension to put in front of the thrombus and do a manual aspiration with the Cath Extension. That you increase a lot your aspiration power. We put, you see here, the Cath Extension. We make another aspiration and we put a stent, and this is the final result. So this situation we have in the setting of STEMI, the use of dual lumen and Cath Extension to increase our success. Guide catheter extension, anatomy and purposes. So we have the rationale is to improve our support. We know that we can, to improve support, we can have deep guided catheter intubation, to use 7 or 8 French, to use 1 or multiple body wire, you can see here on the left, or to use guide extension. In the last 5 years, we have an increase, a huge increase of use of this device. Or balloon, anchoring balloon technique also. But the concept is that with the support of the mother and child technique is great, is crazy in respect of other of the normal guiding catheter. You can see here with the guide liner, if you put guide liner 5 millimeter distal to the ostium, or 10 millimeter, or 15 millimeter, you can see here how the backup support increase in your coronary artery. This is very important. We have many of these guide catheter extension available now in the market. We have the Guidion, we have the guide liner, we have the trap liner for CTO, is fantastic. Is a guide liner with the trapping balloon inside. I think it's the best guide catheter extension for CTO when you need to use a microcatheter. Then we have other new one. We have the Guidezilla from Boston Scientific, or the telescope from Medtronic. We have 3 techniques fundamentally to advance the guide extension. The first one is direct advancement, but sometimes the support is not enough and you are not able to do that. The second example is to put a balloon distal and to anchor yourself in order to push your guide catheter extension. And then to put a balloon halfway inside, outside of the tip of the guide extension, and to facilitate, once you deflate the balloon, to facilitate the crossing with the guide extension. This is direct advancement. In this case, you can see here, we need to reach the PDA to put a stent. We're not able to do that without guide extension, and we were able to advance here the guide extension, and then to put balloon and stent. This is the technique of direct distal anchoring. We have a balloon here. This is a saphenous vein graft. We have a balloon here, and then with the balloon inflated, you can advance distal in the graft. You can see here the guide extension. You have no problem to do that. And then deflating the anchoring balloon, you can advance very, very distal your guide extension. Another example of distal anchoring, you have the balloon. This is another right coronary artery. You have the balloon inflated, you advance. You can see here coming the guide extension. You inflate, you deflate, you push distal, and then you can put a stent. When you push the guide extension very distal, you can easily put a stent inside of your guide extension. This is the third situation in which you need to inflate a balloon halfway inside the distal part, the tip of the guided catheter extension, and then you advance together. The balloon is a small balloon in this situation, then you deflate and you push your guide extension. We can do guide extension assisted rotational atherectomy when you have a very complex situation and you need to have a protection of our coronary artery. This is a case I perform in a female of 82 years old that was treated by PCI of left main circ some day before for ACS. And then she had this very calcified LAD diagonal lesion, you can see here. But we have a drug-eluting stent in the left main circ that was put 4 days ago. So we need to protect our left main. So in this situation, we can put the guide extension here, and then inside of the guide extension, we can do rotational atherectomy. It's very important to know the size. With the 7 French guide extension, you can rotate with the up to 1.5 millimeter Burr. With 6 French guide extension, you can rotate only 1.25 Burr. This is very important. In this case, we rotate with 1.5 in the diagonal branch. You can see here. Then after that, we put a stent. You see the guide extension is in the same position. We put a stent easily. And then we rotate the LAD with the same Burr. And then we put a stent and we do the bifurcation technique with good result, angio and IVUS. So take home message, mother and child, 7 French is compatible with 1.5 Burr, and you can use child and mother as proximal protection. In this situation, we have 2 possibilities. The first one is to assemble outside of the patient the Burr inside the guide extension. And this is the easiest way to avoid friction at the level of transition in the guide extension. But sometimes you are not able to do that because you need to push your guide extension with distal anchoring, and you can put the Burr when the guide extension is in place in the artery. I published the first in man guide extension assisted rotational atherectomy with 2 wire, and this is the case of, I think, 2-3 years ago. Was really complex patient, complex calcified lesion, 3-vessel disease. We treat the right with the Rotablator and the circ with Rotablator also, and we need to treat this LAD diagonal. You can see the calcification is here in the diagonal and in all the LAD. So we start with 8 French guiding catheter. We perform rotational atherectomy with 1.5 and 2 millimeter Burr in the LAD. This is the 2 millimeter Burr. And we decide to stent the LAD, but not the bifurcation, because we need to treat the diagonal. In this situation, this is the paper we published on a urine intervention. This what you have to keep attention to this strategy. So we have 8 French guiding catheter. We have a wire in the LAD, and outside of this wire we put like a body, like alongside, close to the wire, we put a guide extension 7 French here, and we put the Burr inside of the guide extension. So in this situation, we protect the wire on the LAD, because otherwise we will cut this wire. We are not able to do without the guide extension. So we have rota wire in the diagonal and the normal wire in the LAD, guide extension here at the level of bifurcation, and we can rotate the diagonal. So in this situation, you can do rotational atherectomy with 2 wire protecting with the guide extension and the wire on the LAD outside. Then we perform DK crash, left main LAD, diagonal, kissing balloon, and final very good result in this complex situation. Then, very important point is how to solve complication. Guide extension can be really useful for managing of Burr entrapment during rotational atherectomy. This is one case of a calcified lesion of the right. We were on radial approach. You can see how the tortuosity of our subclavian right radial. And we have a Burr entrapment of 175 Burr. You will see here, you will see the entrapment of the Burr. In this situation, what can you do? You need to, this is a video I performed by myself. you need to cut the system with a scissor. You need to remove the sleeve of your burr and trap in the artery, and then you can put your guide extension inside. And you know, the burr is entrapped in the artery, so you have a very strong support. You can push, is a sort of distal anchoring. You see, the burr is entrapped, and you can push your guide extension in front of the burr. You can see it's easy because the burr is blocked in the artery, so you can push easily. And then when the guide extension is in front of the burr, you need to pull together guide extension and wire, and you succeed 100% of case of removing the burr, maintaining the guiding catheter in the ostium. You can see you remove the wire and the burr and the guide extension, but the amplatz is still in place. This is a check, and then PCI and final result. So to conclude, in the modern era of interventional cardiology, patients who undergo complex PCI for high-risk anatomy are commonly encountered in clinical practice. We know every day we need to treat this patient, and we are pushing the envelope every day to do more complex patient, but we need to have very good results. So it's very important to have to know how to treat this patient, and the treatment of this patient require advanced skill from the operator, the availability of dedicated device. Don't forget the use of imaging. IVUS is, I think, is essential. In my practice, I perform CTO PCI, IVUS guided in more than 70% of cases. I perform left main PCI with IVUS in more than 90% of cases, and also bifurcation lesion, because we need to have a very good result mechanically. We have need to have a very good stent implantation to have a good result at follow-up. And the appropriate use of dedicated devices can help to make the treatment of complex anatomy more efficient and safe. The two most important devices, the new devices in my mind, are dual lumen microcatheter and guide extension that should always be available in your shelf. Use of state-of-the-art dual lumen microcatheter can increase efficiency of bifurcation. Thank you very much.
Thank you very much. Very nice presentation. Very neat tricks that we can use in the cath lab. Maybe any comments from the panelists, Dr. Hatem, Dr. Saeed?
I'll probably start with a comment. Thanks, Professor Gabo, for an enlightening and a very informative presentation on some practical tricks that we can use in the cath lab for complex PCI. My question pertains to case number 2. You beautifully illustrated a number of techniques that an operator can use to enhance the support in delivering devices down difficult anatomy. I noticed that even though you had a wire down that RV marginal branch, where you could have used the balloon anchor technique to deliver the stent down, you opted for a guide catheter extension. So my question is there a particular algorithm that you follow? Is there a stepwise approach to how you build your support during complex PCI? Or you've just, from your vast experience, have had more success with guide catheter extensions as opposed to balloon anchor and as opposed to the use of buddy wires?
Yeah, this is a very good question, and we want to be practical, so I think that I thank you for your question. In that case, guide catheter extension was really important for thrombus aspiration. And that's why we decided to use because we aspirate manually with I think was eliminate or export device. I don't remember, but the result was poor because there was a huge amount of thrombus. So in this situation, I tried some years ago to see if, like in an emergency situation, if we were able to increase our success with the guided catheter extension, thrombus aspiration. We know that is a sort of off-label technique, but really efficient. So in that case, guided extension was used for thrombus aspiration, and then we had in place the guide extension, and we use that for stent implantation. So that's particularly related to this case. I like very much anchoring balloon because I think that when you are performing CTO PCI and you start, the good strategy start from the beginning. And if you have a very good support from your guiding catheter, I always use Amplats left for right coronary artery during CTO, for instance. And I use very much a lot of time anchoring balloon. Anchoring balloon give you a fantastic support. So I agree with you that is the first step algorithm in this situation. Sometimes is in different situation when you are not able to deliver balloon on stent normally in the distality of a vessel, very tortuous and calcified. Sometimes anchoring balloon is not enough. In this situation, I suggest to switch to guide extension. That you can really push with this technique. I show like distal anchoring or the balloon halfway inside outside. You can push distal, and once you push distal, the guide extension you can easily cross with whatever stent you have.
Any comment?
I think regarding this case, the presence of two wires prevent the use of aspiration catheter. If it is 6 French, it will not go with another wire. You have to remove the other wire so that you can go with the aspiration catheter. Is this with you also, Dr. Roberto?
Yeah, but it depends on thrombus catheter because with the, for instance, with the eliminate of Terumo is the profile is lower than the other one. You can use also with 2 wire. You can try to use that. With bigger thrombus catheter, you need to have 7 French, or you need to remove your body wire in the side branch. Is right.
Okay. Okay, can I ask a question regarding the first case, left main? You did it through, the operator did it by radial approach with 6 French catheter. And sometimes the lesion was in ostial. And sometimes the radial approach, the catheter is not coaxial and can cause this problem. Whether do you recommend the femoral in this case to avoid this? And if dissection happens and you don't have IVUS, how to make sure that you are in the true lumen and not in the false lumen with the wire?
Yeah, I think that this is two very important points. And I think that the first point is that the operator made a mistake. And it's clear because normally we do, normally I use radial approach or left main guiding catheter. So I think that it's not a problem of access. Normally when I go retrograde, for instance, I have to open the right artery and I have to go retrograde from the LAD. And I have 1 radial, 1 femoral, for instance. I always use right radial for the left main and femoral for the right artery. So I think that is not a problem of radial but it's the problem, I think, of probably, as you said, of the alignment between the guiding catheter and the left main. I agree. The second problem is that the injection of contrast, because probably the pressure was damping, I don't know, and the operator make an injection and cause the dissection. And the third point is that it's very important point. Once you have a dissection, you have not to inject again contrast, because many operator, they think that they want to see more. They don't understand, they inject. But if you have a dissection, because your guiding catheter make a dissection in the left main, you inject, you increase the space of your subintimal dissection. So it's very important what you say in this situation. If you have time, you need to use IVUS to understand what happened in your left main. But in that case, you have seen was an emergency situation, because the patient went in cardiac arrest. So the operator was lucky to put a wire blindly in the LAD, and then he opened the left main LAD, but he has the occlusion of the circ. In this situation, he tried to blindly went to the circ, but he failed. In this case, he was able to, with dual lumen, because he was lucky to take the first wire in the true lumen into the LAD, but the second wire in the circ was in the first lumen. So with the dual lumen in the first wire in the LAD, he was able to gain the circ with the second wire.
Okay.
Thank you.
I have a
Thank
question.
you so much. Maybe we keep with the time, Amru, and
Okay.
you can present. So Dr. Amru, interventional cardiologist from Salalah, he has a very nice case, and that will open up probably more discussion as well.
Okay. Good evening, everybody. Thank you for the panelists for having me today in this interesting webinar. So I will discuss today the effect of systematic approach and strategy planning on primary PCI success and efficiency. So our case today, it's 49 years old male patient, no risk factors except for smoking. He came with typical chest pain more than 12 hours, unfortunately. And when he arrived to our center, he had mild residual pain. His high sensitivity troponin was high, of course, because of late presentation. Echo showed a mild LV dysfunction around 45% and apical hyperplasia. So this is his ECG. As you see, it is evolved anteroseptal myocardial infarction with cues in the anteroseptal leads. But still, the patient is, according to the guidelines, in the still in the window of primary PCI, as you see here, from 12 hours to 48 hours, even if asymptomatic and stable patient, it is class 2A. So we took the patient urgently to the cath lab. Our approach was a right radial axis, 6 French. And usually I go for the right in anterior MI with diagnostic catheter. Then I go straight ahead with PL3 guiding catheter from Toronto. So this is his right coronary artery, as you see. This is a bicranial view. There is some moderate disease, diffuse disease in the BD. The left system, he had tight lesion in the circ, but the LAD, as you see here, and as we expected, this is the culprit lesion. We had a tight proximal to mid lesion in the LAD. So this is from the first look, this is a culprit lesion. So I proceeded with LAD wiring and dilated the LAD with 2.512 balloon. But after carefully looking to the LAD, I noticed that there is some suspicions that there is a branch occluded here. So this is the importance of taking other views. So I took the areocranial view, and this confirmed that there is a diagonal occluded here. So this is a diagonal, as you see here. And as a rule in primary PCI, we don't underestimate any occluded branch, because mostly this is the target lesion. So we proceeded with wiring of the diagonal to see how big this diagonal is. It was a little bit difficult wiring. The run-through failed. Then I took whisper extra support, also failed, but with balloon support, the whisper passed the lesion. Then I dilated the diagonal with a 212 and then 2.515, multiple dilatation. And this is the result after dilatation of the diagonal, and also giving intracoronary tyrofibran and nitrates. So now we have a very big diagonal comparable to the LAD size. So after that, we had to have a break. Of course, it is not a coffee break, but it was a break for strategic planning before proceeding with bifurcation stenting. So as you know, for strategy planning for any bifurcation lesion, the first step is baseline assessment of the bifurcation anatomy. And this is very important regardless the strategy or the technique you are going to use. So we have to assess the anatomy. So we have 4 criteria to be assessed here. The first is the classification. The Medina classification here is 0111. And the second criteria is the diameters of the 3 vessels of bifurcation. As you see here, you may appreciate that the diagonal and the LAD are of comparable sizes, and the diagonal is very long also as LAD, and both are 2.75 to 3 millimeters. And if we use the equation, the mother equals 2/3 of daughter 1 plus daughter 2, the LAD is at least 4 millimeters proximally. So the third criteria is to see the angle. So the angle here is around 50, 45. It is an Y bifurcation, less than 70. The fourth criteria is the distribution of the plaque. As you see here, the diagonal lesion is long, and it extends beyond the ostium, more than 5 millimeters ostium, and we have thrombus in the diagonal, but fortunately there is no thrombus in the LAD or at the ostium of the diagonal itself. It is beyond the ostium. The distal LAD is diseased. Proximal LAD and carina, at least angiographically, has no much disease. So what now? What we'll do? 1 stent or 2 stent strategy, and if 2 stent strategy, which 2 stent strategy? So this is a nice algorithm for bifurcation stenting modified from Manus Prelakis. So the first step is if we need to preserve the side branch or not. In our case, of course, we need to preserve this big and long diagonal. The second step is to see the risk of side branch closure and the disease in the side branch. Of course, our side branch is disease is more than 5 millimeters beyond the ostium, so we have to go for bifurcation 2 stent strategy. The third step is to see the angle, the bifurcation, distal bifurcation angle, and our case here is Y bifurcation. So we are left here with mini crush, decay crush, and clot. So we chose the decay crush technique, and in the next slides, I will go step by step for what we did. So after wiring of both branches and pre-dilatation of the LAD and diagonal, the first step is side branch stenting. And there is two steps here. The first step is to protrude the side branch stent into the main vessel around 3 millimeters in order not to miss the ostium. And the second step is to park a balloon in front of the side branch, and we use this balloon for here, after stenting the diagonal with 275/23, the second step is to give a test, angiogram, to do angiogram, to exclude dissection, any complication before removing the wire and crushing the side branch stent. So next step is the first crush. And we crushed the stent here by a 312 Trek balloon. And the fourth step is the first rewiring. And this is a key step in the DK crush technique to rewire the most proximal strut, as you see here, or at least the middle strut. And to avoid to go distally, because distally it can go under the strut, and after dilatation, this crushed stent will be deformed. So the first step is the first kissing. We did kissing with 2, 3, 12 NC balloons in both branches. And the next step is to position the main vessel stent. And important step here to position the stent just or at least 10 millimeters proximal to the carina in order to have a room to final bot. Then we inflated the stent in the LAD. This is 330 resolute, sized according to the distal vessel size. And this is the second crush. Then we did bot by 4/8 NC Trek balloon. And usually the second rewiring is difficult in DK crush, but after the first kissing, balloon inflation, and the first bot, usually the rewiring is more easier, like you see here. Then the next step is to do the second kissing. We did with 3.58 in the LAD and 312 in the diagonal. First sequentially by high pressure inflations in both branches, then we end by the kissing balloon inflation. The last step is the second and the final bot. And the most important step here is to position your balloon just proximal to the carina in order not to destroy the new carina, as you see here in the stent post. And this is the final angiogram, final result in the orocranial view. And this is the LO cranial view. Just 2 slides regarding the antiplatelet therapy in this patient. According to the guidelines, this patient should take ticagrelor or prasugrel, because this is a STEMI. This is a class 1A for at least 12 months. Unfortunately, this is not available in our man, so we give him clopidogrel for 12 months. Low-dose aspirin, of course, is lifelong. And regarding prolonged DAPT, more than 12 months is class 2B. And if we calculate the scores, the bleeding risk here is very low for this patient. So he might benefit from the prolonged DAPT. Unfortunately, we don't have randomized trials for prolonged DAPT in the bifurcation lesions, but at least we have the COBIS II Registry with prolonged DAPT in bifurcation stenting, and this is published in 2018. And it showed that the prolonged DAPT group had less all-cause of death and less cardiac death, less MACE, and even less incidence thrombosis. And this benefit was maintained in the subgroup, all the subgroup analysis. So my take-home message is strategy planning and systematic approach is very important for primary PCI efficiency and success. And we should take our time to assess and plan before proceeding with bifurcation stenting. And although provisional stenting till now is a good, the gold standard technique, however, every operator should be familiar with at least other two stent strategy techniques, one upfront and at least one bailout technique. So on behalf of Salalah Heart Center, we would like to thank you all for inviting us, and we wish to see you maybe next year and visit us in the green and beautiful Salalah in summer, next summer, inshallah. Thank you.
Thank you so much, Amru. Very nice illustration. Any comment, Dr. Hatem, on what you saw?
Thank you, Mr. Chairman. A beautiful and a very illustrious case, Dr. Amr, and I'm particularly fond of the stepwise approach to the technique of DK crush stenting. My question is, you emphasize the importance of crossing back into the side branch through the proximal most struts. Short of using intravascular imaging, how do you actually ensure that you have crossed through the proximal most struts and avoiding the distal struts?
Okay, thank you, Dr. Hatem, for your comment and question. This is a very important question. Usually it is very difficult, but by zooming, you zoom, and sometimes you, if you have a balloon in the main vessel, you can do stent boost, and you try to see if it is proximal or distal. And this is the only way without intravascular imaging. But I agree, it is sometimes it is difficult to be sure that you are in proximal.
Dr. Saeed? Sorry. Go ahead, Hatem.
Continue, Hatem.
Sorry, one quick comment. You've beautifully shown us the justification for why you use the DK crush technique, but would you have considered, say, for example, a V-stent?
V-stenting for this?
Mm-hmm.
Yes, it can be, but I'm not sure if you can just adjust your stents precisely at the LAD and the diagonal. So it can be done, of course. It's one of the techniques in this case with 011 you can do.
Okay.
Dr. Saeed?
Okay, thank you, Dr. Amr, for this very educational case. And you are good that you noticed the loss of this diagonal artery. And also you can see that there is another clue that the LAD is not showing any branches and this area is clean. The diagonal area is clean from arteries. Yeah. But I don't know whether there is another option for provisional stenting in this case, because it is acute STEMI, and although the diagonal is a culprit and there was persistent ST elevation in 1 and AVL, but it was opened nicely by dilatation, and you can provisionally stent and do bill out stenting of the diagonal, and you have another circ lesion which needs to be done during this admission, and you can relook for the diagonal, because DK crush in emergency is time-consuming radiation, and I know that you are busy in Salalah with a lot of emergencies, and you are one of the lucky doctors. You have a lot of emergency cases.
Yes. Okay, thank you, Dr. Saeed, for your comment. Regarding this, the DK crush, choosing of the DK crush technique, I thought twice before proceeding with the DK crush technique. But what encouraged me that the disease and the diagonal is it is a very tight and very long segment, and it required a lot of dilatation with 2, and then I realized this is a very big diagonal. We upgraded the balloon to 2.5, and it was very tight lesion. I don't think the just provisional will be enough for this. And what encouraged me also that the distribution of the thrombus is after the ostium of the diagonal, and there is no thrombus in the LAD. And even after multiple balloon dilatation, the flow was excellent in the diagonal. So that encouraged me that even if I will go with further steps and multiple steps, nothing will happen. And the anatomy and the angle encouraged me to go. And the patient was stable at that time, so I was not in a hurry.
Okay, thanks.
Thank you very much, Dr. Amro, for a very nice illustration, very nice case.
Yeah.
Dr. Garbo?
Yeah, if I can make a comment, I want to congratulate for a great presentation. I want to discuss about just 2 points. The first one, that using a lot of IVUS, we know that this stenting get not a good result in the long term, and because it's impossible to have a good ostial expansion of both branches. So I agree that is not the ideal situation. Try not to do that. And the second point is the importance of have the stent in the main vessel enough length to obtain a good pot, not to involve the diagonal. So it's very important when you are performing this DK crash or mini crash, to have the stent in the main vessel proximal to the bifurcation. It has to be at least 10 millimeter proximal in order to have a good pot with 8 millimeter non-compliant balloon, avoiding to compromise the bifurcation. This is a very important point, and using a lot of imaging, this is very clear after the procedure.
Excellent, thank you. Thank you, very informative comment. Sticking to the time, we move to Dr. Muntasser with another great case, I think. The floor is yours, or the screen is yours.
Shukran, Adel. Thank you very much, everybody. Okay, let me share my presentation. Okay. So actually, can you hear me clearly, everybody?
Yes, it's clear.
Okay, thank you. So now I'm going to present this case. Actually, for me, it is one of the most challenging cases I've ever faced, either in my long practice in Palestine or here in Oman. It was a case of a 68-year-old gentleman, thin, with a body mass index less than 20 kilogram per meter square. He had a history of coronary artery disease, CABG done in 2000, and newly discovered diabetes mellitus, has peripheral artery disease manifested by abdominal aortic aneurysm repair in 2017. Severe central chest pain was his main presentation, and aborted cardiac arrest twice in the emergency department by DC shock. And his ECG revealed acute inferior MI, so immediately cath lab activated, as we have in Salalah Heart Center, 24/7 primary PCI service. So the initial preparation, the patient, I choose the right femoral approach because, of course, we have CABG grafts. Although our default approach is the radial, 6 French Judkin left and right diagnostic catheters, 6 French Judkin right guiding catheter for the PCI trial, The wires were BMW and Whisper. Initially, I used with the balloon and, of course, anesthesia backup. So the first left coronary diagnostic revealed what you can see here. Chronic total occlusion from the osteoproximal LAD, a tight ostial circ, and a subtotal obtuse marginal occlusion. His right coronary angiography revealed the mid segment of the RCA was totally occluded as well. And then the SVG to RCA revealed what looks like acute thrombosis causing this abrupt occlusion from the proximal segment. And this looks to be the culprit, of course. And then finally, we have one good news that the lima was patent in this poor patient. So to start with, we have now a background of total occluded LAD, subtotal LCX, patent lima, occluded native RCA, and acutely occluded SVG. So what strategy should I start with? Now, because of the known better outcomes of opening the native vessel, although I know it will be challenging, but I opted to start to try with the native RCA, because if I succeeded, that would be much better for the patient and to avoid the difficult outcomes or the inferior outcomes of doing PCI to the SVG graft, which is acutely thrombosed. And we know that it's up to 15 to 20% sometimes the no reflow results can be. So started with the wire after trying BMW wire, then Whisper wire was needed with the support of a small balloon. And actually I passed almost 2/3 of the occluded segment, but unfortunately while we are trying doing that, the patient developed another attack of ventricular fibrillation. Can you hear me?
Yes.
Okay.
Yes. Okay.
So, tamam, thank you. So the DC shock was given and patient at this stage was intubated. So I need to change my strategy at this time. So after failure of passing this and the patient deteriorated, I then opted to move to try opening the culprit, the SVG, saphenous venous graft, to RCA. Now, the first trial with the BMW wire didn't pass easily the anastomosis area, in spite of also recurrent ballooning at different levels, trying to support the wire, but couldn't pass. And again, the patient developed another attack of ventricular fibrillation, which made us remove the wire and the balloon at this stage. So after giving the DC shock, again we gain spontaneous cardiac output for the patient, and he's now intubated but still hemodynamic unstable. So I kept the same strategy but with the new tactics. I changed the wire with a new one, as the tip of the previous wire was damaged with the trials. New balloon as well. I used export catheter for both thrombus aspiration to try as much as we can, although I know the thrombus burden was too big for that. And also to help as a microcatheter support for the wire. Also, I consider giving glycoprotein 2B3A inhibitors, and the patient was unstable at this moment. Anyhow, I could manage to pass the wire with the help of this micro aspiration catheter, and then multiple thrombus aspiration performed. But of course, as expected, also we couldn't get the needed flow yet. So patient now, this is the the stage now. Patient is critical with hemodynamic instability, recurrent ventricular fibrillation, failed native RCA PCI, still no flow in the culprit SVG after changing wires, balloons, inflation, recurrent thrombus aspiration, and giving intracoronary tirofiban. So here the decision was to go one step up with this elderly patient, around 70-year, thin, but we need to get the flow in this gentleman who is hemodynamically unstable. So I decided to give intracoronary thrombolysis in the graft. We gave Retrieval 10 milligram, which was repeated after 30 minutes. And actually the second dose was given through the microcatheter itself. So finally, good flow was obtained, and at this moment we thank God and we took a deep breath that the procedure is going to be successful, hopefully. So this was, and after we got this flow, we can recognize the two culprit lesions. One was in the distal and another proximal lesion was there. So I stented the distal one with a 3 by 16 millimeter drug limit stent, and the proximal one with 4 by 23 millimeter. This was the stenting of the distal, and here the proximal, and then no reflow. And there was an idea to use the distal protective device, but with this unstable patient, time matters. So I hope that stenting them quickly can at least end the story and help him much. So again, I'm stuck. This patient again is still critical. Both lesions stented nicely, but no reflow. So I decided at this stage again to combine mechanical and pharmacological measures. So recurrent ballooning for the distal and proximal stents mechanically, and also I administered intracoronary graft adenosine 12 microgram and nitroprusside. And I have some experience with this before that helped a lot actually, but in native. And it's the first time to use it in saphenous graft PCI. 400 microgram nitroprusside in 2 boluses were given, and we can get this result finally with a good flow in the graft, as well as the distal RCA with the main branches. So after getting this STEMI 3 flow in the culprit SVG to distal native right coronary, hemodynamically, shortly the patient stabilized. He was extubated next day and discharged home after 6 days from this procedure. So I can conclude here that intracoronary graft thrombolysis can be a last solution in such challenging acute occluded and thrombosed saphenous vein graft with a big thrombus burden, not responding to other mechanical or pharmacological measures, as well as that intracoronary adenosine and nitroprusside can be very helpful in treating post-PCI slow flow or no reflow phenomena. So if we will just summarize some take-home messages, the first message that myself I learned from this case, that never give up early, also never give up late as well. In primary PCI, you need to try all your weapons until you get the flow back. Combining mechanical and pharmacological measures usually increases your chances of success. And finally, maybe in the next time, if I can have more time, then whenever feasible, I will use embolic protection devices in SVG PCI to minimize the no reflow phenomena. And thank you so much. Thank you.
Thank you, Dr. Montasser. What a great case. It's a nightmare you don't want to have, but I think you need to be congratulated for the excellent result. Dr. Saeed, any comment?
Yes, congratulations, Dr. Muntasir, for this very challenging case. And we know that saphenous vein graft intervention is very problematic, and long-term results and restenosis, thrombosis, it is very frustrating, and we don't have much progress in this case. Thrombolytic therapy intragraft, I saw many cases, case reports, but there is no guidelines. There is no guidelines about the dose. Some they are giving full dose, some are giving bolus infusion, but no guidelines. We saw in this case aspiration, which is very important, and we saw in Dr. Roberto case also aspiration. Although it is downgraded by the guidelines, we are against this. When it indicated, it has to be used. But in saphenous vein graft, we have to make sure that the guide catheter is well inside the saphenous vein graft, because to prevent dislodgement of any thrombi. But if I have a similar case like this I presented in Gulf PCR, and I have an hypothesis about SVG, if you want to share with me or you agree with me. I think the occlusion, if you can show after lysis, Dr. Muntasir, the most tight lesion is the culprit lesion is down in the SVG. And the contrast can't penetrate this lesion, tight lesion down is caused the stagnation of blood and the smoke, if we can see by IVUS, and also thrombosis. But if we can reach this tight lesion down, we may succeed to open it, the lesion and the SVG. I can share with you this case. Only 2 slides. Okay. I hope it will work. You will see that. Okay. I have similar one, and after the deflated balloon was going, and then the SVG also is like this. But when I got this idea, I inflated a balloon and I went down, and then the balloon stopped, and I recognized that there is a lesion here. So I deflated the balloon and then passed the balloon, and you saw the waist here. I inflated it, and then I got the flow. If we can get this, okay, I will stop. If we can, sorry, how to go in again to stop sharing?
There is a red color button up.
Okay, so if we can go to this tight lesion, if we can detect it either by this poor blind technique, primitive, or I think better by IVUS, if we go there and see the lesion and see the thrombus and see the size of the SVG, we can, I think, get better results in these cases. I want to know the opinions, if any, Dr. Roberto.
Dr. Garbo, any opinion on you're on mute.
Yeah. Okay. Yeah. I agree with the presenter. Then saphenous vein graft is a really frustrating procedure because we have a bad result. But in this case, this is clear that try to open the native during a primary PCI without distal visualization of the right is quite impossible. This is the problem. So in this situation, the key is that when you are performing primary PCI, you need to open the graft. You need to restore the fluoro, also because you are in an emergent situation with multiple ventricular fibrillation, and you have no way to open to avoid the opening very fast the graft. The problem of distal embolization is very high in this situation. You have huge amount of thrombus. So in this case, I want to be really without injected contrast. I want to have a very good manual aspiration with guide extension or mechanical aspiration with angiojet. I have a very good experience in that. When you have this huge amount of thrombus, the mechanical aspirator is very good in this situation. The problem is that when you have a degenerated saphenous vein graft and you can see the distality, and you are not in primary PCI setting, but sort of a acute coronary syndrome with suboccludent graft, with the huge diffuse disease of the graft, I suggest always try to open the CTO of the native artery. And the last point is that when you need to use drugs to increase the flow, the distality, I use adenosine, I use nitroprusside as the presenter, and I have a very good experience also with a very low dose of adrenaline, of infusion through a microcatheter. You can go distal to the microcatheter and you can have a small infusion like 50 micrograms. So very small, low dose of adrenaline. You can have a very good result on the flow or the distality of the vessel.
Yeah, I agree with you, Dr. Garbo. If I may mention that, yes, I agree with you that trying with this native vessel in this situation, the chance was actually low to succeed, but sometimes you are extraordinarily lucky enough to do. If I could, then I think it will be much better to avoid those complex situation, the SVG. But finally, of course, I have to go again to the culprit, and good that I could manage finally and with those trials. Yeah.
You did a great job. You did a great job in very complex situation, because with the recurrence of ventricular fibrillation is you're in a very bad situation. So you try everything, and at the end you succeed. And then what we discussed about Said, that sometimes you have a stenosis that can decrease your flow, and that's what I think the good comment that of Said, that try to use this technique of pushing a small balloon up to distal. You can understand if the graft is stenotic or only with thrombus. That is right, Said? You agree with that comment?
I think that's what he was showing us, Dr. Said.
Yeah. I think it was a great technique. Right?
Yeah, it's a smart idea and simple one, and I think it helps a lot. Thank you, Dr. Said.
You have a question?
Thank you.
Yes, I have a question to Dr. Garbo regarding the technique of aspiration through the guide extension. Did you experience any stroke after that? With any stroke with patients?
Yeah, good comment. You know, I didn't have any stroke of that. It's important that you put the guide extension of the same size than the guiding catheter. So you need to avoid to have some space between the guide extension and the guiding catheter, because in this is the risk to have a space in which the thrombus can go between the two guides. So if you have a 6 French, you have to go with the 6 French guide extension. If you have a 7 French, you need to go with 7 French guide extension. And you need to, one technique useful is to put a balloon, a small balloon distal, and to anchorate like a distal anchor to push the guide extension. And then while the balloon is inflate, you can aspirate And so you reduce the risk of embolization of the thrombus on the distality. And you need to put your syringe at the level of Y connector, clearly. And normally we use a big syringe, like 50 cc syringe with the lock, in order to have a very good force to aspirate. But we never have a stroke in this situation, fortunately.
And to close the Y connector directly.
Yeah, and then you can put a very strong force and at that level, and you can see really when sucking of your syringe and the vacuum of the syringe, and you can have a great aspiration of thrombus in this situation. Because, you know, if you have this huge amount of thrombus, if you embolize distally, it's quite impossible to restore a good flow, because you have all the distality is full of thrombus in that situation. And also the use of microcatheter to have an infusion is really useful. Like Antonio Colombo explained that if you don't have a microcatheter, you can cut a balloon, and then you can make it as a microcatheter. Yeah, you can use a balloon to have an infusion. But if you have a microcatheter, it's easy to have, or a dual lumen microcatheter, you can have an infusion of drug in the distality.
Okay. Another question to Dr. Garbo. So regarding the nano crush or nano decay crush, have you any experience with the nano decay crush?
The nano with the, what you mean with the nano?
There is some proposed techniques regarding the nano decay crush, regarding the protrusion of the stent, is just very minimal protrusion, not the 3 millimeters in the main vessel. Then they do, I think this is...
The mini?
No, nano. It is proposed by some Indian group, and then tested again in some British group, published in, I think, in 2019. The main differences is the protrusion. They just protrude the side branch stent in the main vessel. It's just maybe just adds the ostium, just protruding maybe 1 millimeter, like nano crush. Then they take the balloon, the stent balloon, and use the stent balloon and the barked balloon in the main vessel for the first kissing. Then they crush, then they do the further step. So they say that the less metal is better, and it will, you know, decrease the mace.
Really, I didn't have any experience on it. That's technique. I think that's, but I don't think it's in my mind that can make the difference to have an increase in the success, because I think that in this situation with the nano probably, but I didn't try. You risk to have a sort of geographic miss at the level of the ostium of the side branch, and this what we want to avoid performing a mini crash. Do you agree? I think that with this point, that what you explained very well, that you need to have to enter in the proximal strat in order to avoid the miss of the ostium. So if you go in the distal strat, you risk to have a miss also. And in this nano, I think that you increase the risk to have a miss of the sort of ostium of the diagonal without strats. I think that it's much more important in this situation have a 3 millimeter of protruding in the side branch, have a good main branch, as you explained, stenting part proximal to the bifurcation. Use IVUS in order to be sure to have a very good result, to have a good kissing balloon with the single step kissing, side branch, high atmosphere, main vessel. eye, and then kissing and pot. I think that this is much more important, but because we need to avoid, if you have a geographic miss, you can have a problem in the follow-up.
Okay, thank you.
There is a question from the attendees. It says, during complex PCI, multi-wires are in coronaries and sometimes guide catheter thrombosis. What is the next step? Can you aspirate thrombus by aspiration catheter without removing the catheter? Maybe Dr. Garbo, I don't know if you understood the question.
Yeah, I think that this is an important question in every complex PCI. Mainly in CTO, we know that the thrombosis of donor vessel is the most dangerous complication we can have, because we have many complications in complex PCI. You can have perforation, you can have dissection, but you can have thrombosis. But the thrombosis can be really a catastrophic complication. And if you are doing a retrograde PCI, you have thrombosis of the donor vessel, you can have a cardiac arrest in 30 seconds. So what I suggest in every complex PCI, you have to try to avoid this kind of thrombosis in the guiding catheter. So you have to be sure that your ACT is more than 300 in every situation. And in this situation, when you think that you have something that doesn't work in your guide wire, you have a sort of clot, you can see, avoid, and you have to be careful that the pressure in the monitor is good. When you have a damping pressure or you have a clot in the wire, you can suppose to have a thrombosis. Don't inject, because the injection of contrast can perform a sort of embolization thrombus. Once you have this thrombosis that can happen, you need to I think, in this situation, try to remove all the wire that are not necessary, and try to have a good aspiration over the single wire in the main vessel.
Thank you, very clear. I think this second question is probably, I'll ask Dr. Muntasir, because I think it belongs to him. In cases of large thrombus burden in SVG PCI, is there a rationale for anticoagulation long-term? So in your patient who had a large thrombus burden, you discharged him on dual antiplatelets, correct?
That's true, yes.
Yeah. You did not consider anticoagulation in him?
No, and I will not.
Okay. Anybody in the panel, Dr. Garbo, Dr. Saeed, Amro, Hatem? Anybody would consider anticoagulation in that case?
Oh, for me, no.
Okay, so Dr. Abu Bakr Sheikh, you got your answer there. Nobody is considering. Yeah. So, thank you very much. Any comments?
I might consider it, Adil, if there is ectatic native coronary with this big burden of thrombus, then yes, I might consider it. Yeah. But in this situation, it's just acute, let's say, plaque rupture there, which caused this thrombus, which is just incident now because of the acute event. And in this old Baba, I don't think that there is any indication for long-term anticoagulation.
Yeah, and I think the shaking of the heads, they all agree with you. Okay. Any comments before we wrap up? Any comments from the panelists? Okay, so I'm just going, excellent presentations. I really enjoyed, all the talks. What have I learned? Complex PCI, is it a complex patient? Is it a complex anatomy? Is it hemodynamic instability? It's probably a combination of all that. There's no such a thing as a simple PCI. We say it, but many times we forget it. And if you're complacent, you don't take care, you might get into troubles and nightmares which you actually were not looking forward to. We use, in our lab, we have used NHancer, we have used Sasuke. I did not know that NHancer was the only one that could be trapped in a 6 French. So now I have a new favorite dual lumen catheter, although I was happy with Sasuke. Good guide extension to aspirate if your regular aspiration catheter does not seem to do the job. I think that's a nice demonstration of how to use it. Tricks of anchoring, I think we've discussed that, and advancing the guide catheter extension, balloon facilitated tracking, or distal anchoring. We have seen nifty and novel techniques of rotablation using 2 guide wires by protecting one guide wire with a guide extension. I think that was very brilliant, actually. I don't think, it's amazing that you thought of that, actually. Use of guide extension to retrieve entrapped Rotablator. I think that is the nightmare that I fear the most, that my Rotablator would be entrapped and I wouldn't know what to do. I hate calling the surgeon. Image guided PCI, obviously, whenever you can, will result in better outcomes. And Dr. Amru showed us very nicely, step by step, how he did the DK crush. He stopped, to think about what to do next. And that stopping might maybe 30 seconds or a minute, but I think the overall results eventually will be great if you stop and think. Dr. Muntasir, STEMI nightmare, did not give up, and I congratulate you. Many people would give up after the second VF and say, you know what, this patient has cabbage, he's elderly, there's nothing else we can do, but you persisted, and I think you were greatly rewarded. Bailout thrombolysis. And so I think I have learned a lot from all of you guys. Thank you, Dr. Garbo, for excellent presentation. Thank you to our presenters, Dr. Amru and Muntasir, for excellent cases. Dr. Saeed and Dr. Hatem, panelists, thank you for your contribution. Thank you very much. I just want to remind everybody that there is a survey that you need to fill at the end of this presentation. Dr. Garbo, thank you very much.
It was a great pleasure, Adil. So I was honored to be a part of your webinar, and thank you very much for your invitation. So it was really a pleasure for me. I hope to see you soon.
Thank you.
Thank you. Stay safe.
Thank you
Stay
so much.
safe.
Thank you, everybody.
Thank you.
Thank you.